There is a certain comfort that we all just sort of take for granted when we walk into a modern hospital.
Oh, absolutely. The clean floors, the uniform.
Right. You see the gleaming linoleum, the quiet hum of the MRI machines, the doctors in those crisp white coats, and you just assume, unconsciously really, that you're inside a fortress.
You feel safe.
Exactly. A place where science has built this massive wall against the chaos of the natural world. But what if that wall is an illusion?
Well, that's the thing. It often is.
Right. What if the real battle isn't happening in the surgical theater at all, but in these microscopic spaces we can't even see?
Yeah.
And driven by massive, unseen economic and political forces.
That is the exact unsettling reality we really have to confront today. We're looking at a system that is, on the surface at least, performing miracles every day. But beneath that surface, the very foundation of the fortress is fracturing.
So welcome to you, our dedicated listener, the learner. We are so thrilled you're joining us for this custom-tailored deep dive. Okay, let's unpack this.
Let's do it.
Today, we are immersing ourselves in the staggering complexity of the Indian healthcare system.
Which is massive.
It is. It's a network designed to care for 1.4 billion people. But the sources show it is currently experiencing just profound systemic distress.
Yeah, distress is putting it mildly.
Seriously, we're going to trace the entire life cycle of this crisis. We're starting at the very root, which is how doctors are educated, and the intense commercial pressures they face right out of the gate.
And then we'll follow those doctors as they either flee to the West or enter these severely underfunded hospitals.
Right, and look at the terrifying biological consequences of poor infection control. Specifically, the rise of untreatable superbugs.
Silent pandemic.
Exactly. And finally, we're going to examine this radical AI-driven technology that's being proposed as a desperate firewall against a post-antibiotic world.
But before we get into the mechanics of all this, we really need to establish a very clear baseline.
Yes, please.
The material we are analyzing today is incredibly dense and, in many areas, highly politically charged.
Very much so.
We are looking at documents that contain severe critiques of government policy, detailed allegations of high-level institutional corruption, and extremely heated debates over things like, well, caste-based educational quotas.
Exactly. And to be absolutely clear up front, our role here is to impartially report and synthesize the information from this giant stack of materials you've provided us.
Right. We aren't taking a stance.
No, we aren't here to endorse or validate or take sides on any of these viewpoints or political debates. We are simply holding up a mirror to the documents, breaking down the arguments and explaining how all these complex systems interact.
If we connect this to the bigger picture, you might be sitting in London or Sydney or New York wondering why the internal mechanics of a healthcare system halfway across the world matters to your daily life.
Right, like why should I care?
Exactly. It matters because biology doesn't care about geography. A systemic vulnerability in a nation of 1.4 billion people is a vulnerability for the entire human species.
Microbes don't need passports.
They really don't. The superbug that evolves in a fragmented hospital ward today can easily be in your local emergency room tomorrow.
So let's start right at the foundation, medical education. Because to understand the doctors, you really have to understand how they are made.
And India produces an astonishing number of them.
Yeah, the numbers are wild. We're talking about 612 medical colleges churning out roughly 91,900 MBBS graduates every single year.
Which is huge.
And for anyone unfamiliar, the MBBS is the primary medical degree there. It's basically the equivalent of an MD in the States.
Yeah.
At first glance, those numbers sound like a massive triumph of scale.
They do. They really do. But when you look at the actual mechanics of how that scale was achieved, a very, very different picture emerges.
It's all about the money, isn't it?
Pretty much. The turning point, according to the documents, is a landmark 2002 Supreme Court ruling. It's known as the TMA Pay Foundation case.
Okay.
This ruling fundamentally shifted the whole landscape. It established the right of private citizens and organizations to set up educational institutions.
Which sounds good on paper.
Right. But crucially, it gave them the autonomy to determine their own fee structures, completely separate from the heavily subsidized government colleges.
And this is where the floodgates just violently opened. It wasn't just like a slight premium for private education.
Not at all.
The documents detail that securing a seat in one of these private medical colleges can cost anywhere from 2 million to 4 million Indian rupees. every single year.
Yeah, which translates to roughly 25,000 to 50,000 US dollars annually.
In a country where the median income is just a tiny, tiny fraction of that, I mean, who can actually afford this?
Very few people. And that is the core issue. What's fascinating here is how the 2002 ruling inadvertently created an environment perfectly primed for hyper-commercialization.
It became a business.
An incredibly lucrative one. It became highly profitable to just open a medical college. And when you have that kind of massive, sudden financial incentive paired with a mandate for rapid expansion,
Quality control just vanishes.
inevitably the regulatory oversight breaks down.
And breakdown might be a huge understatement here. The materials point to corruption at the absolute highest echelons of medical oversight.
It goes right to the cop.
Like in 2010, the Medical Council of India, the MCI, which is the supreme regulatory body for medical education in the country, they were entirely dissolved by the government.
Yes. The president of the MCI at the time, Ketan Desai, was literally arrested by the Central Bureau of Investigation. He was caught taking massive bribes to grant official recognition to a private medical college that didn't even come close to meeting the required standards.
And the logistics of how these colleges fake their standards are just wild. The documents describe this concept of ghost faculties.
Oh, this part is incredible.
It really is. Basically, when an inspection is scheduled, the college essentially rents doctors from other clinics just for the day.
Just for a few hours, really.
Yeah. They put them in white coats, have them walk around the campus so the inspectors see a fully staffed institution. And the second the inspectors leave.
The doctors go back to their real jobs.
Exactly. The college gets officially recognized, but the actual students are left with totally inadequate instruction. They're paying millions of rupees for ghosts.
It's the theater of compliance. And it is driven by this intense pressure from the top down.
To hit a quota, right?
Yes. The government has been aggressively pushing to reach a World Health Organization ratio of 1 doctor per 1,000 patients.
Okay, 1 to 1,000.
But what's really interesting in our stack of sources is that they point out this specific WHO metric is largely unsubstantiated.
Wait, really? It's just made up.
It's a target that has taken on a life of its own. It's driving policy towards sheer quantity, regardless of the quality of the doctors being produced.
So they're rapidly expanding a compromised system just to hit a largely arbitrary number.
That's what the sources suggest.
That makes no sense. I mean, I guess if you desperately need doctors, you could argue that building more private colleges is better than nothing. But it sounds like we're trying to put out a fire by building a new fire station, but we're staffing it with people who had to buy their fire hoses on the black market.
That's a great way to put it.
If the doctors are paying massive capitation fees, which the sources define as essentially huge, under-the-table donations just to get a seat, how does that impact the kind of care they eventually provide?
Well, it completely warps their career trajectory. Think about the economic reality of a student who graduates with that level of debt.
You need to pay it off fast.
Exactly. They are under immense, immediate pressure to see a return on their investment. They simply cannot afford to take a low-paying government job in a rural, underfunded clinic.
Even though that's where the doctors are needed the most.
Precisely. They have to chase high-paying specialties in corporate hospitals in major urban centers. So the private sector expansion doesn't actually solve the rural healthcare shortage at all.
It just creates a highly indebted workforce clustered in the cities.
Exactly.
And that is just the private tier. The pressure to get into the highly subsidized, prestigious government medical colleges is a whole different kind of nightmare.
It's incredibly intense.
The documents include this fascinating, really raw Reddit thread from a forum called Indian Med School.
Yeah, that thread was eye-opening.
It really was. These are actual medical students on the ground, and their frustration is just palpable. They're describing the entire medical education system as thievery, masquerading as capitalism.
The main bottleneck they are facing is the NEET exam, the National Eligibility Cum Entrance Test.
Right.
This is the single gateway to medical education in India. You have over 2 million highly stressed students fiercely competing for roughly 100,000 seats.
2 million kids for 100,000 spots.
Yes. Only about 2.8% of the students who take this exam will actually manage to secure a spot in a government college.
That level of scarcity breeds intense resentment, especially regarding how those few seats are distributed.
Which brings us to the quotas.
Yes, the materials highlight a massive controversy over the reservation system, the caste-based educational quotas. The students in this Reddit thread are incredibly vocal about this.
They are.
They feel the selection process is punishing academic talent in favor of social quotas.
And this is where we have to look at the raw mechanics of the system objectively, as outlined in the text.
Right, staying totally neutral here.
Exactly. The reservation policies were historically designed to address deeply entrenched social inequalities, to give historically marginalized groups a chance.
Sure.
However, the operational reality of how this plays out on the NEET exam creates massive mathematical disparities.
Yeah, one specific complaint from the thread really highlights this. A student in the general or unreserved category might need a cutoff score of, say, 150 just to qualify.
Right.
While a student in a reserved category might only need a score of 50.
It's a huge gap.
It is. And the students arguing against this on the forum expressed deep fears that letting students in with such drastically lower scores is ruining the overall quality of medical education. They argue it leads to substandard doctors.
Analyzing this strictly from a systems perspective, what we're seeing is the inevitable friction of artificial scarcity.
What do you mean by that?
When a resource as life-altering as a subsidized medical degree is so severely limited, any mechanism used to distribute it is going to cause anger. Whether it's the ability to pay millions of rupees for a private seat or a social quota for a government seat, it becomes a flashpoint for extreme societal frustration.
Because everyone is just desperate to get in.
Exactly. The overarching theme from all these educational sources is that the foundation is cracking. The system is prioritizing commercial scale and numerical targets over equitable access and rigorous meritocratic training.
Which sets up a very dangerous domino effect. Because if you take the brightest young minds, put them through a hyper-competitive, deeply flawed educational meat grinder,
right,
and then saddle them with either massive debt or intense systemic frustration, what do?
They leave.
They leave. We move from the foundation to the exodus, the brain drain.
And the data on this is striking. It indicates that nearly 45% of medical students actively want to study or train abroad.
Almost half.
Yes, primarily targeting the United States and the United Kingdom.
Here's where it gets really interesting, though. It's not just a passive desire to travel. The documents suggest this exodus is actually being actively cultivated by the private sector in India.
It's built into the business model.
Yeah. These massive corporate hospitals in India aren't focusing on primary care or infectious disease management, the things the rural population actually needs.
No, they focus on high-end, technologically advanced specialties.
Like complex robotic surgeries or specialized oncology.
Because those are the specialties that perfectly align with the needs of Western healthcare systems.
Wow.
The private hospitals in India are essentially operating as highly efficient launching pads. They groom these doctors for the export market.
Which is just an incredible paradox. You have India essentially funding the healthcare systems of the wealthiest nations on Earth.
This raises an important question regarding global health equity.
Yeah, the global North gets an influx of highly trained professionals without having to pay a single cent for their decade of foundational medical education.
It is a massive transfer of wealth and human capital from the global South to the global North. But what's fascinating and deeply troubling to the doctors involved is what happens when they actually arrive in these Western systems.
Right. It's not a red carpet welcome.
Not at all. They often face significant systemic barriers.
The documents include a very detailed account from Dr. Kadiyali Srivatsa. He's an Indian-trained doctor who moved to the UK.
And he has a lot to say about the regulatory bodies there.
He is fiercely critical of the UK's General Medical Council, the GMC, which regulates doctors there. He argues that foreign medical graduates, specifically those qualifying in non-European countries, are treated as second-class professionals.
He points specifically to the regulatory hurdles. Doctors trained outside the UK or Europe are required to pass what are known as PLAB exams.
The Professional and Linguistic Assessments Board.
Exactly. These are rigorous exams designed to prove their medical competence and communication skills.
Which, okay, sounds reasonable at first.
But Dr. Srivatsa notes that even after passing these exams, they are often forced to work under strict supervision as junior doctors for up to 5 years before they can practice independently.
I have to push back a little here, though, just based on what we read. Isn't that just standard quality control?
The GMC would certainly argue that.
Right, because if you're importing a doctor from a medical college that, as we just discussed, might have literally faked its faculty for an inspection.
Yeah, the ghost doctors.
Exactly. Shouldn't a medical board like the GMC test them rigorously and supervise them? It seems like basic patient safety.
That is the exact defense the regulatory bodies use: patient safety and standardization of care. But Dr. Srivatsa's argument is about disproportionate barriers.
How so?
He contrasts the immense difficulty a highly qualified foreign doctor faces with the relative autonomy granted to local non-physician staff.
Oh, like nurses.
Yes. He notes that a local nurse in the UK can eventually operate independently as an independent nurse practitioner and prescriber.
Making diagnostic and prescribing decisions.
Exactly. While an internationally trained doctor with a full medical degree and years of experience back home is kept under years of restrictive supervision.
So he sees it as a double standard.
He frames it not as quality control, but as institutional discrimination and gatekeeping by the GMC.
You know, it's wild. You might be treated by an incredibly skilled Indian doctor in London or New York, but consider the systemic vacuum their departure left back home.
The brain drain is very real.
And while these highly trained doctors are fighting these regulatory battles in London, look at what's happening back in India. The documents highlight the ultimate crushing irony.
Medical tourism.
Yes. India is one of the top global destinations for international patients. People from wealthy countries fly into Mumbai or Delhi, go to a state-of-the-art corporate hospital.
And they get a world-class cardiac bypass for a fraction of what it costs in the U.S.
And then they fly home. Billions of dollars flow into these corporate hospitals from medical tourists.
But on the exact same day, in the exact same country, a rural farmer dies from a totally preventable, easily treatable infection.
Because there isn't a single doctor within a 50-mile radius. The talent has either been absorbed by the corporate medical tourism bubble, or they've boarded a plane to work for the NHS.
It leaves the domestic public health infrastructure completely hollowed out.
It's tragic.
It really is. And that brings us to the reality of the hospitals that are actually left to care for the vast majority of the population. Let's look at the system under strain.
The financial numbers here are just incredibly bleak. Historically, public health spending in India has hovered around an abysmal 1.28% of its GDP.
Which is painfully low.
They have a stated goal of reaching 2.5% by 2025, but right now, the per capita spending, the amount of public money spent on health per person, is about $73.
And for context, the global average per capita health spending is $1,110.
Wow.
So the Indian system is trying to provide care with a fraction of the resources.
And to make matters worse, the resources that do exist are managed in what the sources describe as vertical silos.
Right, this is a crucial structural flaw.
Meaning the system is incredibly fragmented. So, like, the department fighting tuberculosis operates completely independently from the department fighting malaria.
Yes.
And neither of them has effective communication with the local public hospital.
Precisely. There is an almost total lack of horizontal communication.
Which means what, practically?
Well, in a functional system, data and resources flow seamlessly between departments. But when you have vertical silos, you get massive administrative redundancies, you get blind spots, and you have a complete inability to respond to complex, multi-layered crises.
And India faces crises of scale that simply don't exist anywhere else.
The crowd management issues.
Exactly. The document spent a lot of time analyzing crowd mismanagement during mass gatherings. We're talking about events like the Sabarimala pilgrimage, the Kumbh Mela festivals, or massive stadium events in Bengaluru.
We are talking about gatherings of literally millions of people.
The analyses of these events repeatedly point to catastrophic planning failures. Stampedes and crushes occur because there is no real-time communication infrastructure.
And a severe lack of coordination between the local police forces and the civil administration.
The physical infrastructure simply cannot bridge the demand-supply gap when millions of people converge at once.
But it's not just an infrastructure problem. It's a profound behavioral and corruption issue.
Yeah. The sources note that people routinely just ignore safety rules, and the enforcement mechanisms are fundamentally broken.
There are documented accounts in the text of police and administrators actively accepting bribes.
Or just turning a blind eye because of gift-giving, allowing people to bypass safety protocols entirely.
Which becomes an epidemiological nightmare. Think about it. When police accept a bribe to let people bypass a health checkpoint at a massive festival or a crowded wedding,
they are potentially allowing infected individuals to mingle unchecked in some of the densest crowds on Earth.
Exactly. And the ultimate stress test of all this fragmentation and rule-breaking was, of course, the COVID-19 pandemic.
Naturally.
The documents provide a very nuanced, balanced look at how the system reacted. It wasn't entirely a failure.
Right. There were massive logistical triumphs. The government built the Cowen digital platform. That successfully facilitated the administration of over 1.6 billion vaccine doses.
Which is a staggering technological achievement, honestly.
Absolutely. And they leaned heavily on the ASHA workers, the accredited social health activists.
These are local women trained as health educators in their own villages.
Yeah, and they were incredibly effective at grassroots outreach, bridging the gap between the formal health system and the rural population.
But where the system required complex horizontal coordination, it buckled completely.
We all remember the horrifying images of the oxygen shortages.
The supply chain vulnerabilities were massive. Up to 30% of pharmaceutical factories faced lockdowns because they were entirely dependent on active ingredients imported from China.
And then there was the infodemic.
Oh, the misinformation was as deadly as the virus itself.
Because public trust in the fragmented health system is historically low, people turned to unregulated information networks. WhatsApp and Facebook became vectors for incredibly dangerous medical rumors.
The documents specifically mention rumors that burning camphor or chewing clove could somehow cure the virus.
When you have a massive population relying on WhatsApp forwards for medical advice instead of doctors, you lose all control of public health interventions.
You really do.
But honestly, as bad as the pandemic was, it was the everyday routine failures inside the hospitals detailed in these sources that truly shocked me.
You're referring to the infection control data?
Yes. The statistics on hand hygiene are terrifying. In Indian hospitals, overall hand hygiene compliance ranges between 30% to 67%.
Which is already bad.
But when you look at the breakdown by profession, it gets worse. Doctors comply with hand washing protocols only 37% of the time.
Wow.
Nurses are at 35%. Paramedics are down to 23%.
And we have to look at when they are failing to wash their hands.
Right.
The World Health Organization has a strict protocol called the 5 moments for hand hygiene. The most critical moment is before touching a patient.
Because that is the exact moment you risk introducing a foreign pathogen into a vulnerable person's system.
Exactly. And one study cited in the documents found that compliance before touching a patient was a staggering 11%.
Okay, so just imagine this. You walk into a hospital clinic right now. There is an 89% chance that the person who is about to examine your open wound or insert an IV line has not washed their hands.
It's hard to process.
It is. And then there's the glove paradox.
Yeah.
This is the detail that absolutely blew my mind.
It's a perfect example of systemic dysfunction.
Because these hospitals are operating on pennies, they face severe resource constraints. So instead of throwing away disposable nitrile or latex gloves after seeing a patient, they wash them.
Yes.
They wash them, try to dry them, and reuse them on the next patient.
And here is where the mechanical failure of the system becomes glaringly obvious. A detailed economic analysis was conducted on this practice.
Okay.
When you calculate the cost of reprocessing a single pair of disposable gloves, which includes the labor time of the staff, the soap, the water, the electricity to run an autoclave or dryer, and the logistical transport, it costs the hospital 14.33 Indian rupees.
Wait. But the cost to just buy a brand new, perfectly sterile, bulk manufactured pair of gloves is only 9.90 rupees.
Exactly.
How is this possible? It literally costs them more money to do the incredibly dangerous, unsanitary thing that defies all logic. Why would any hospital administrator allow this?
It defies logic until you understand the psychology of a system in constant survival mode.
Walk me through that.
This happens because of procurement bottlenecks and the difference between visible and invisible costs. The 9.90 rupee cost of a new glove requires a direct budget approval, a procurement order, and a functional supply chain.
Okay.
If the supply chain is broken or the budget is frozen by a bureaucrat somewhere, the hospital physically doesn't have the new gloves in the supply closet.
So they just use what they have.
Exactly. The 14.33 rupee cost of washing the glove is a hidden or sunk cost. The nurse is already on salary. The water is already running. They aren't writing a physical check for 14.33 rupees every time they wash a glove.
I see.
So out of sheer desperation, put something on their hands before touching a bleeding patient. They resort to a practice that not only destroys the structural integrity and sterility of the glove,
But actively turns it into a vehicle for cross-contamination.
Precisely.
It is the ultimate symptom of a broken management system. When you have overwhelming patient volume and chronic underfunding, the invisible threat, the bacteria being passed from patient A to patient B on a reused glove, is ignored.
Just to manage the immediate visible crisis of the patient crashing right in front of them.
And ignoring that invisible threat for decades has cultivated what the documents call the silent pandemic. We are moving from the macroscopic failures of hospital administration directly into microscopic warfare.
We're talking about antimicrobial resistance, AMR.
Right. We casually use the word superbugs, but the data in these sources paints a picture of a slow-motion apocalypse.
The numbers are grim.
The projections estimate that AMR will claim 169 million lives globally by the year 2050. 2 million of those deaths will be in India alone, and it's expected to cost their economy up to $2.4 billion.
To put the current lethality into perspective, the sources state that right now, in India, antimicrobial resistance causes more mortality than cancer, tuberculosis, respiratory infections, and diabetes combined.
That is horrifying. How does it get this completely out of control?
The documents point to a massive multi-front failure. First, there is the widespread, completely unregulated over-the-counter availability of antibiotics.
People are simply self-medicating.
Yes, and we have to understand the socioeconomic drivers behind this. If you are living in poverty and you are illiterate and the nearest government doctor is 50 miles away, what do you do when you get a high fever?
You go to the local pharmacy.
You go to the pharmacy, you buy the strongest antibiotic you can afford, often without a prescription, and you take it for 2 days. The moment your fever breaks and you feel slightly better,
you stop taking it. To save the rest of the pills for the next time you get sick.
Which is the absolute worst thing you can do.
Let's explain the biology of why that's so dangerous. Because when you take a 2-day underdose of an antibiotic, you aren't wiping out the infection. You are essentially just poisoning the weakest bacteria.
They die off, yes.
But the strongest, most resilient bacteria survive the attack. They learn what the drug looks like, they mutate, and then they multiply. You are actively training the bacteria to defeat the medicine.
Precisely. It is an evolutionary arms race, and we are handing the enemy our playbook.
And the pharmaceutical industry is heavily implicated in the documents, aren't they?
Oh, absolutely. We are talking about a $41 billion industry in India. The sources highlight intense, cutthroat, competitive pressure among drug manufacturers.
Which leads to what?
It drives aggressive sales tactics. Medical representatives actually incentivize pharmacists and doctors to push massive quantities of broad-spectrum antibiotics, regardless of whether the patient actually has a bacterial infection or just a viral cold.
But it's not just human consumption driving this.
Yeah.
The environment itself has been turned into a massive bioreactor.
This is where it gets truly systemic.
The sources describe a horrifying convergence in the soil and water. You have open defecation from a massive population mixing with totally unregulated toxic medical waste dumped by hospitals.
Mixing with agricultural sludge.
Right.
The agricultural component is vital to understand. The poultry and livestock industries use massive amounts of antibiotics
to treat sick animals.
Not just to treat them, they use them to promote growth and prevent disease in incredibly crowded, unsanitary farming conditions. The animals then excrete largely undegraded active pharmaceuticals right into the soil.
So you have human waste carrying resistant bacteria from the hospitals, meeting agricultural waste packed with active antibiotics in the groundwater.
Yes. And bacteria are incredibly efficient at survival. They engage in something called horizontal gene transfer.
What is that?
They can literally pass small packets of DNA, called plasmids, to completely different species of bacteria.
Wait, really? Across species?
Yes. So a harmless bacteria living in the soil can encounter agricultural antibiotics, mutate a resistance gene, and then pass that resistance gene directly to a deadly human pathogen in the water supply.
We are literally marinating the environment in deleted antibiotics and pathogens.
We are. And the Indian Council of Medical Research, the ICMR, released data proving exactly how fast we are losing this war.
Let's look at the numbers for Klebsiella pneumonia.
Yes, the data on this is alarming.
For those who don't know, this is a nasty bacteria that can cause severe pneumonias, bloodstream infections, and meningitis, particularly in hospitals. The ICMR tracks its susceptibility to a drug called meropenem.
And we should note, meropenem is not a standard everyday drug. It is a powerful, broad-spectrum carbapenem.
It's the heavy artillery.
Exactly. A drug of last resort used when everything else fails.
Well, in 2018, the ICMR reported that Klebsiella pneumonia had a 15% susceptibility to meropenem.
Which means the drug only worked 15% of the time, which is already a disaster.
Right. But by 2022, just 4 years later, that susceptibility had plummeted to 2.5%.
The drug is functionally useless.
And it's not just the rare bugs. E. coli, an incredibly common bacteria that causes everything from food poisoning to urinary tract infections, now has an efficacy rate to common drugs that has fallen below 20%.
The pharmacological armor is failing. And what makes this pandemic so incredibly difficult to fight is what the documents refer to as the silent spread.
So what does this all mean?
Well, when the general public thinks of a deadly pandemic, they picture COVID-19 or Ebola. They picture high fevers, aggressive coughing, and people visibly severely ill.
But the sources warn that the AMR pandemic will be 10 to 20 times more challenging to control precisely because it doesn't look like a pandemic.
Exactly.
It's a boiling frog situation. COVID was a sudden explosion, but AMR is a slow boil. A person carrying a highly resistant superbug might not have a fever at all. The symptoms can be incredibly subtle or completely hidden.
They might just have a painless pimple or a faint, slightly itchy rash or just a general feeling of lethargy.
The documents specifically note that many of these silent vectors could be carrying drug-resistant sexually transmitted diseases. Because the symptoms are mild or easily ignored, these individuals have no reason to isolate. They feel fine.
So they go about their lives. They go to work, they go to the crowded markets.
They attend those massive weddings and festivals where the police have been bribed to ignore crowd control.
Yes. And as they move through the world, they are silently shedding these untreatable superbugs onto every surface they touch. Door handles, mobile phones, the clothes of the people brushing past them.
They are unwitting, highly mobile biological weapons.
And the systemic response to this silent threat is practically non-existent. The documents detail severe policy failures here.
Like what?
Out of all the states and union territories in India, only 4 Kerala, Madhya Pradesh, New Delhi, and Andhra Pradesh have actually drafted action plans for antimicrobial resistance.
Only 4.
And state-level bans on over-the-counter antibiotic sales exist on paper, but enforcement on the ground is 0.
The timeline the sources present is chilling. They warn that if there is no massive intervention, by 2028, we will enter a true post-antibiotic era.
2028 is right around the corner.
It is. This means that routine, everyday medical procedures will become incredibly dangerous gambles. A minor outpatient surgery, a routine C-section, even a scrape on the knee for a child could result in an infection that doctors simply have no drugs left to treat.
Neonates newborns in the ICU will be at massive risk of untreatable sepsis.
If the bacteria are adapting faster than we can invent new drugs, aren't we fighting a losing battle with medicine alone?
We are looking at the unraveling of modern medicine. If the bacteria are mutating faster than the pharmaceutical industry can invent new classes of drugs, and we haven't discovered a major new class of antibiotics in decades, by the way.
We cannot fight this battle with medicine alone.
No. We have to shift our entire paradigm from treating infections after they happen to preventing transmission before the patient ever reaches the hospital.
Which brings us to the final and perhaps most fascinating part of our deep dive today, the technological intervention.
This is a radical shift in strategy.
The sources present a very specific solution proposed to bridge this exact gap. We return to Dr. Kadiyali Srivatsa, the same doctor who criticized the UK's GMC earlier.
Yes, he has developed a system called the Prima kiosk,
which stands for Personal, Reliable, Empowering Medical Access.
Yes.
And it is powered by an artificial intelligence known as Dr. Maya AI.
It is absolutely vital to understand what this technology is designed to do and what it is not.
Right. It's not a robot surgeon.
No, it is not a robotic doctor. It is not designed to diagnose your exact illness and print out a prescription. The Prima kiosk is designed as a decentralized, community-owned early warning triage network.
I try to picture it like this. If the AMR pandemic is a massive invisible gas leak in a house, the hospital is the fire department. Right now, the fire department only shows up when the house is already fully engulfed in flames. The Prima kiosk is the smart smoke detector. It senses the invisible danger before the fire starts and tells you to get out of the house.
That's a very functional way to look at it. Let's look at the mechanics of how a user actually interacts with it.
Yeah.
Imagine a kiosk placed in a high-traffic, accessible area, a shopping mall, a busy railway station, or a rural community center.
Somewhere easy to get to.
Right. A person walks up, perhaps feeling just slightly off. The AI prompts them to input subtle symptoms. We aren't just talking about high fevers.
It's looking for the silent spread.
Exactly. The AI is trained to look for the hidden signs. Unusual sweating, subtle mood changes, a faint rash, unexplained lethargy.
And then Dr. Maya, the AI, uses complex pattern recognition. It analyzes combinations of these seemingly unrelated symptoms and cross-references them against emerging epidemiological data.
And again, it doesn't give a medical diagnosis. It gives a risk assessment using a simple, universal color-coded system.
Walk us through the colors.
Green means you are fine. There is no immediate risk. Yellow indicates caution. Monitor your symptoms. Pretty standard. Yes. But blue is the critical trigger. It indicates a high probability of an underlying infection risk, meaning you need to isolate and see a general practitioner within 24 hours.
And red.
Red, obviously, is a medical emergency requiring immediate hospital intervention.
The primary strategic goal here, according to the documents, is identifying clusters of these silent infections before they reach a clinical setting.
This is the preventative aspect.
Yeah. Dr. Srivatsa explicitly references the horrific death toll among healthcare workers during the Ebola epidemic to make his point.
That's a grim but accurate parallel.
During Ebola, hospitals became the primary vectors for transmission. Infected patients crowded into waiting rooms, infecting the doctors, the nurses, and the uninfected patients who were just there for, like, a broken arm.
If a network of Prima kiosks can detect a cluster of blue risk profiles in a specific neighborhood, public health officials can isolate those individuals at home or direct them to specialized containment clinics.
You actively prevent the silent spreaders from ever walking through the doors of the main hospital.
Exactly. Thereby protecting the vulnerable healthcare workers and the immunocompromised patients inside.
There is also a very powerful economic argument attached to this pitch. The system is designed to drastically reduce the burden on completely overwhelmed public health infrastructures, whether that's the underfunded clinics in rural India or the strained NHS in the UK.
It filters the demand.
Right. The documents claim that a huge percentage of emergency room visits, up to 40%, are from the worried well. People who just have a minor viral bug but demand an emergency appointment out of fear.
By filtering out the worried well with a green code at a local kiosk, you free up massive amounts of clinical time and resources.
And it generates revenue, too.
Yes.
Yeah.
The financial model presented in the pitch claims that if just 10 users interact with the kiosk per day, it can generate over £18,000 annually.
The idea is to create a self-sustaining microeconomy of community health that doesn't rely on massive government funding.
But, as with any disruptive technology, there is massive resistance.
Oh, of course.
Dr. Srivatsa claims in his writings that he has desperately tried to alert the highest levels of government.
Yeah, the texts mention this. He states he has sent detailed information about the impending 2028 AMR crisis, along with a copy of his book outlining the Prima Kiosk solution, directly to Prime Minister Modi and the Indian Health Minister.
And his claim is that he has received absolute silence. No response whatsoever.
Just totally ignored. And he alleges this isn't just bureaucratic inefficiency. He believes it's an active structural suppression.
He's pointing the finger at entrenched interests.
Right. The documents claim that there has been little to no investment or interest in this kind of preparedness because entrenched bureaucrats control the government grants and philanthropic funding, effectively stifling any grassroots innovation that bypasses their authority.
Furthermore, he argues that pharmaceutical companies and device manufacturers actively lobby against decentralized triage networks.
Because tools that prevent illness and filter out unnecessary consultations inherently reduce the volume of drugs and tests they can sell.
It's a fascinating allegation. The idea that the medical industrial establishment is threatened by a technology that empowers the patient outside of the traditional, highly monetized clinical encounter.
I have to play devil's advocate here, though, regarding the kiosk.
All for it.
Let's look at the human element. The technology might be incredibly sophisticated, but we just spent an hour discussing how people routinely bribe police to bypass safety rules at weddings.
True.
Are these same people really going to trust a standalone kiosk next to the food court in a mall? If a machine flashes a blue light and tells a guy his painless rash might be a superbug and he needs to cancel his work shift and isolate, is he actually going to do it?
That is the ultimate vulnerability of the entire concept. It requires a monumental behavioral hurdle.
A total shift in mindset.
Exactly. Shifting a massive population from a mindset of reactive sick care, where you only go to a doctor when you are incapacitated, to proactive healthcare, where you monitor invisible risks and act for the collective good, is incredibly difficult.
Yeah, that doesn't happen overnight.
Dr. Srivatsa himself notes in the documents that if this system isn't implemented and normalized now, it will be impossible to train staff and foster the necessary cultural mindset change before the 2028 crisis hits.
But look at the alternatives we've mapped out today. If you don't have enough doctors,
right,
and the doctors you do have are forced through a corrupt, hyper-commercialized educational system where seats are bought with capitation fees. And if the brightest of those doctors flee to face discrimination in the UK.
It's a bleak picture.
And if the hospitals left behind are so underfunded that washing a disposable glove is standard economic practice. And if those hospitals are actively breeding untreatable superbugs.
When you put it all together like that,
An AI triage network might not just be a neat technological idea. It might literally be the only scalable bridge left to protect the public from total systemic collapse.
The through line of everything we've unpacked today is profound vulnerability. We have examined a system where commercial incentives have vastly overshadowed the fundamental ethics of care, and where bacterial biology has rapidly outpaced our pharmacological innovation.
And to you listening to this, I want to reiterate why this matters to your life. We are living in a globally connected biological ecosystem.
We really are.
The fragmentation of healthcare in India, the misuse of antibiotics, the silent spread of mutated pathogens, these are not localized problems. A pathogen that learns to defeat our strongest antibiotics in an unregulated farm or an understaffed clinic today will board a plane tomorrow.
The era of assuming a magical pill will cure whatever ails us is rapidly coming to an end.
Systemic vigilance, radical transparency, and technological innovation are becoming our only lines of defense.
I want to leave you with a final thought, something to mull over that builds on the implications of Dr. Maya AI and the Prima kiosk.
Okay.
We have built our modern world on the miracle of the antibiotic. But if that miracle is failing primarily because of human behavior, our greed, our poor management, our refusal to follow protocols, then perhaps the ultimate cure for the next pandemic isn't a new chemical compound at all.
Wow.
Perhaps the future of human survival depends entirely on data, on artificial intelligence, and on our willingness to sacrifice our personal convenience to protect the collective.
That's a heavy thought.
The technological question is whether the AI can detect the superbug. But the far more profound question is, are we culturally ready to let an algorithm tell us that we are a deadly threat to our neighbors, and will we listen when it tells us to stop?
That is the question we all need to answer before the invisible fire really starts spreading. Thank you for joining us on this incredibly dense, vital deep dive. Keep questioning the systems around you, keep looking for the hidden connections, and we will catch you next time.